This conference will now be recorded.
Okay, so now continuing with this second in the series of lectures on the pancreas, this is part 2, and we're talking about acute pancreatitis this time. So, the usual disclosures, as with all lectures. Okay, so first of all, let's start with defining pancreatitis types. When we talk about pancreatitis, what are the type of pancreatitis we are talking about? So, one is what we know as acute pancreatitis, which can also present as recurrent acute pancreatitis, characterized by a reversible nature. It's a reversible entity without leaving any residual changes even after recurrent attacks. That's very important. It's reversible and no residual changes. Two things to be uh, highlighted in context to acute pancreatitis. So it is reversible. That basically means totally reversible. There will be no residual change in this patient. Second is a chronic pancreatitis. This is a gradual destruction of the gland. So see the difference between this was reversible, this is a gradual ongoing destruction of the gland. It is distinct from acute attacks. And majority of chronic pancreatitis, it is not logical to say that every acute pancreatitis is going to proceed to a chronic pancreatitis. So it's not a logical progression from acute, except in a very small percentage of cases. Also, chronic pancreatitis may have an intermittent acute attacks interspersed in between the course of the disease. Right? Now, just a few words about recurrent acute pancreatitis. We'll not be referring to this again because the nature is basically the same as acute pancreatitis, but what sets it apart is the definition. We say that there have to be more than two attacks of acute pancreatitis without any evidence of underlying chronic pancreatitis. So understand what we are saying. So again, it is a reversible attack with no residual change happening twice or more than two times and interspersed with the absolute normal period. Absolute normal period. And because most of the known cause of acute pancreatitis are generally treated, so you don't expect a particular treatable acute pancreatitis to recur again. So it is only those patients of acute pancreatitis where the cause was not treated who would present with recurrent acute pancreatitis. And that's why it is most commonly seen in the idiopathic group of recurrent acute pancreatitis, what is known as the idiopathic recurrent acute pancreatitis, which forms almost 20-25% cases of acute pancreatitis. The causes of idiopathic recurrent acute pancreatitis can be mechanical, toxic, metabolic, anatomical, miscellaneous, just like the acute pancreatitis. The idiopathic group where exact cause cannot be identified. Pancreas divisum is now believed to be a cofactor in a recurrent acute pancreatitis. The sphincter of Oddi as a cause for IRAP remains controversial. Right? Now, what is acute pancreatitis? Now, for that, the standard reference now all over is the Atlanta classification, which for the first time came out in 1992. Why Atlanta? Because the first meeting of pancreatic scientists, surgeons, and pancreatic physicians took place at Atlanta, and they first formulated the classification in 1992. So this classification was later modified in 2013, which we now follow. So we'll be referring to Atlanta classification in the subsequent discussion of acute pancreatitis. Now, this Atlanta criteria of 2013 is the standard for reference, as I told you. Now, why was this standard required? Number one, to remove the large ambiguity of terminology and its various interpretations. Number two, to defer the use of pathological terms at clinical time. Now, initially, when we were studying it way back in 1970s and 80s, it was acute hemorrhagic pancreatitis and acute edematous pancreatitis. These were supposed to be clinical terms. Now, how can that be a clinical term? These are more like a pathological, interspersed the clinical term. So they wanted to have a particular reference, a standard reference. Now, for example, say I am reporting on a patient acute pancreatitis on which I operated. Now I said it's edematous. They may have been areas of hemorrhage. Another person with the same thing may interpret with the same kind of presentation may interpret it as the acute edematous purely. So the interpretation varied. That's why they had to bring out standard protocols and standard definitions so that there could be no ambiguity. So the clinical definition of acute pancreatitis as of now, as of today, it requires any two of the following features. Number one, clinically, abdominal pain strongly suggestive of acute pancreatitis. Now, what is abdominal pain strongly suggestive of acute pancreatitis? It's very typical. How? Acute onset of sudden, persistent, severe epigastric pain, often radiating to the back. That is the standard definition of a pancreatic pain. Okay, so this is a pancreatic pain which has to be very acute in onset. It has to be persistent. It has to be severe. It has to be epigastric pain, often radiating to the back. That is the second thing is a serum lipase and or amylase greater than 3 times the upper level of normal. And number three is a characteristic finding of acute pancreatitis on an ultrasound or a contrast enhanced CT or MRI. That means basically imaging. So if you have any two of these to be positive, then it is a clinically defined acute pancreatitis. And that was the revised Atlanta criteria 2013. That is how they define acute pancreatitis. Now, let's see what causes acute pancreatitis. Why should acute pancreatitis develop in the first place? Perhaps one of the important causes, I would not like to call it the most common because the most common is the second one, that's gallstones. One of the important causes is alcohol and accounting for almost 25% of patients with acute pancreatitis. The reasons are varied. Why does alcohol cause acute pancreatitis? Number of hypotheses to it. I've just picked up the important ones. Number one, in alcohol, in those patients who have alcohol intoxication or alcohol as a cause of pancreatitis, they have number one, increased ductal permeability and pancreatic enzyme extravasation because of either the duct has been blocked, because of proteinaceous material, or because of increased sphincter of foci pressure. There has to be pancreatic hypersecretion as a reflex to counter what? Because when you have alcohol, there's increased acidity. Those of you who are taking alcohol must have experienced it, a lot of acidity. Now that acidity puts an increased acid load to the duodenum. So if there's increased acid to the duodenum, the pancreas has to secrete more bicarbonate. So as a reflex to the increased acidity of alcohol, there's a pancreatic hypersecretion. Alcohol directly sensitizes the SNR cells to cholecystokinin and stimulates intestine to secrete more of CCK. There's a transient hypertriglyceridemia, triggers pro-inflammatory pathway, and there's a dysregulation of cathepsin L and B, which are important mediators in the genesis of acute pancreatitis. But coming to the most important cause, and that is gallstones, responsible for almost 50 to 70% of patients with acute pancreatitis. This figure varies from study to study, but a common range could be 50 to 70%. What kind of gallstone is going to cause a pancreatic precipitation of acute pancreatitis? It has to be a migrating stone. Why migrating? A stone which is migrated from the CBD into the duodenum. Why? Because it causes temporary stenting of the ampulla and it results in what? Biliary and duodenal content reflux. So for a temporary period when there is a stenting of the ampulla, it is open. So that openness of the ampulla leads to the biliary secretion and the duodenal secretion moving back into the pancreatic duct. So it is a reflux of the biliary and duodenal content, which ultimately damage the SNI by the bile salts. This is substantiated. So is there anything to prove this theory? Yes, there are substantiation evidences. And what are substantiating evidences? Number one, 90 of these patients have the ambulatory configuration at CVD pancreatic duct junction. What is the ambulatory configuration? If you remember the last lecture, 60% will be having a common channel known as the ampulla. So see, most of these patients who have acute pancreatitis would also be having an ampullary configuration at the junction. And number two, 90% of these patients would have a demonstrable stone in the stool. So that is reason enough to believe that probably this hypothesis is correct. Or else there could also be a permanent block of the pancreatic duct obstruction because the stone of a gallbladder impacted at that particular point. So that would lead to hypersecretion. Coming to the other causes, ERCP is again important cause. In 1 to 3% of patients with acute pancreatitis, you'll find a history of ERCP. Cause, why does ERCP cause acute pancreatitis? That there is a duct disruption and enzyme extravasation, especially in those cases where ERCP is also accompanied by sphincterotomy or a balloon dilatation. Abdominal trauma, iatrogenic, That means you're doing some kind of a surgery. Most common is a splenectomy, where you're tying the splenic hilum, you're not careful enough, and you tie the tail of the pancreas, which is in close relation to the hilum of the spleen. So what happens? There is acute pancreatitis, the tail of pancreas. There are certain drugs which can lead to acute pancreatitis. 2% of acute pancreatitis are drug related. Metronidazole, a very commonly used drug, azathioprine, steroids, valproic acid, statins, 5-ESA used for ulcerative colitis, and 6-mercaptopurine are some of the drugs. There is a whole list of other drugs. Then any reason for pancreatic ischemia, like for example, a hypovolemic shock or a patient of hypovolemia, patient of severe hemorrhage. All these are increasingly liable to have a precipitation of acute pancreatitis. Idiopathic causes is a major cause in almost 20-25% of patients in some studies. And it has been thought probably these patients will be having biliary slide. Still not proven. The other important causes are metabolic, an increased calcium level, a hyperthyroidism. In both the cases, there's increased precipitation of increased trypsinogen activation, calcium stone deposition, and duct obstruction. In addition, increased triglyceride level, there's a direct pancreatic injury. If there's any reason for ductal obstruction, just like we said, a gallbladder stone, other reasons for duct obstruction, like example, as cariasis, mumps, other viral infections, you could have a carcinoma pancreas, you're having a ampullary carcinoma. Autoimmune is a separate group, and of course, hereditary. Now, coming to the hereditary causes, which forms the important group, especially in those patients where they also have chronic pancreatitis. That also forms a very important group. Genetic genesis of acute pancreatitis as well as chronic pancreatitis. Here, let's stick to the acute pancreatitis. So, genetic predisposition is seen in some individuals, and clinically, these patients often suffer from the recurrent variety of acute pancreatitis, that is RAP, a progression to early chronic pancreatitis. They develop acute pancreatitis in teens, and there's a high risk of pancreatic cancer. So this is true for the genetic alteration which is responsible for pancreatitis. Now, which genes are involved? There's a whole list of genes involved. We'll talk about the genes more when we talk about chronic pancreatitis. But here, just to enumerate those genes, one is the cystic fibrosis transmembrane conductance regulator. The other is the cationic trypsinogen gene. Then pancreatic secretory trypsin inhibitor, or the SPINK1, and of course trypsin degrading enzyme chymotrypsin C, that is the CTRC gene. So the genes which have been identified as causing acute pancreatitis. A mnemonic for the etiology of acute pancreatitis, you want to remember it, you can do that. And there are a number of mnemonics to it, like for example, stay home, bad hits. However, the one which is most commonly used, which encompasses a wider range of causes, is I get smashed, and I stands for idiopathic, G for gallstones, E for ethanol, that's alcohol, T for trauma, then you have S for steroid, which is a drug related, M viral mumps, autoimmune, the other S for scorpion sting, H for hypercalcemia and hypertriglyceridemia, E for ERCP, and D for drugs. That tries to tell you the important causes of acute pancreatitis. Now, we know the causes, but then ultimately what is happening? What is the pathophysiological sequence of events? Now, the inciting events could be a whole range of inciting events, but the primary thing what is happening is the trypsinogen to trypsin activation is occurring within the SNS cell, which it should not, as opposed to in the duct lumen. The trypsinogen should not be in the active form intracellularly. That is the earliest change in pancreatitis. So that means it starts the whole story starts in the SNS cell, in the SNI, SNS cell, not SNI, SNS cell. Inside the SNS cell, the trypsinogen, which was not supposed to be in the active form, has been activated for whatever reason. So, trying to find a common thread in all these disparate causes that we just now enumerated is difficult. There are a number of theories to it. So, the story is starting from the SNS cell. From the cell, it leads to ductal, periductal, and perilobular changes. That is how acute pancreatitis goes on developing. So coming back to the hypothesis, how do these disparate causes? We talked about gallstones, alcohol, etc., etc., etc. We just now enumerated them, and the mnemonic I get smashed. So what is the common thread to all these? So the hypothesis includes number one, either there is a pancreatic duct blockage or obstructive secretion, as we saw with alcohol. right? Or we saw temporarily with the gallstone, or there is temporary stenting with a duodenal reflux as in gallstone. But the most pertinent seems to be something happening at the acinar cell, and that is what is known as the acinar co-localization theory, which causes acinar derangement or injury. And what is this co-localization theory? What are being localized, co-localized? Two things. Number one, the zymogen with the lysosome. What is the zymogen? The zymogen has a lot of digestive enzymes like trypsinogen inside itself, and lysosomes are basically organelle. They are subcellular organelle which are housing enzymes like cathepsin B, which acts as a trypsinogen activator. So now what is happening? They join together inside a cytoplasmic vacuole. Now, once they join together inside a cytoplasmic vacuole, this activator immediately activates the trypsin. So now what is happening? The second stage is that further to the co-localization, the trypsinogen has been activated to trypsin by cathepsin B and other like enzyme. Now, this active trypsin then activates a whole range of other digestive enzymes, right? Like, for example, elastase, phospholipases, and so on and so forth. And once they're activated, the active trypsin also makes these organelle in which they are housed more permeable, so that the elastase, phospholipases, they leak from the vacuole into the cell cytosol. So this was happening inside the vacuole, which was formed because of zymogen with lysosome. Now this vacuole permeability increases. The wall of the vacuole. This, remember, vacuole is what? Inside the cell. So it's a subcellular particle. So inside that subcellular particle, now there's increased leakage of these activated enzymes, along with leakage of the cathepsin B also. So everything is leaking into the cytosol. Now, with this early activation of trypsinogen and the leakage, it leads to cellular injury. But apart from the co-localization, because of direct stimulation of the cathepsin B of the trypsinogen, another problem activator method of route of activation of trypsinogen could also be a problem with calcium hemostasis and pH. Now, calcium transport inside the cell is an ATP driven process. Agreed? Now, many toxins which cause pancreatitis, they lead to ATP depletion, right? Now, this ATP depletion leads to what? An elevated intra-acinar calcium concentration. That means the calcium build up inside the acinar cell. Now, once there is an increased build of calcium inside the cell, it activates what? An early activation of trypsinogen to trypsin. And this causes acinar cell injury and necrosis. So, whether it is a co-localization or it is activation of trypsinogen to trypsin by the increased calcium inside the cell. Either way, what is happening? The acinar cell gets damaged, and that leads to release of what we now understand as damage-associated molecular pattern. Now, what we initially understood as cytokines, leukotrienes, and leukotrienes, etc., 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 that means cellular products which are secreted once the cell gets damaged. These are now collectively known as damage-associated molecular patterns, or DAMPs, and that include the inflammatory cytokines, especially TNF alpha, interleukin 1, 2, 6, prostaglandins, leukotrienes, and platelet aggregating factor. Simultaneously, as happens in any physiological body process, there is a counter regulation to any kind of ongoing process, and here also the counter regulatory anti-inflammatory IL-10 and others are also released to keep this ongoing DMP process under check. Right now, this release of DMPs from these damaged acinar cells is now going to have a widespread effect. What? It recruits neutrophils and macrophages for the local inflammation, which sets up the local inflammation, and it also initiates a systemic inflammatory cascade known as systemic inflammatory response syndrome. So now you see what has happened. The acinar cell has been damaged because of what? Because of intracellular activation of trypsinogen into trypsin, and that has ultimately set up what? An acinar cell injury and destruction, led to what? A release of DAMPs, and those DAMPs, number one, compound the local damage, and by recruiting more of neutrophils and macrophages, setting up local inflammation. At the same time, when they get absorbed in circulation, they would lead to widespread SIRS syndrome. The local pancreatic inflammation is compounded by damage to the vasculature. Now remember, these are all enzymes and they also act on the blood vessel. So apart from the vasodilation, there's also the damage to capillary endothelium, leading to microvascular thrombosis, increased capillary permeability, and thinning of the vessel wall because of the elastase. All this leads to damage and local hemorrhages, local blockage of the blood vessel, further decreasing the amount of blood supply to that particular area of the pancreas. Now, the inflammatory cascade that we just talked about, the DMP is getting absorbed inside the body. It is usually self-limiting in patient acute pancreatitis, 80 to 90% of the time. But there are 10% group of patients with acute pancreatitis where it keeps on increasing. And this pathophysiological event sets up a vicious cycle. The DMP gets released. It sets up acute pancreatitis, goes on, and ultimately leads to massive release of cytokines, setting up what? Into multiple organ dysfunction known as MODS and ultimately MOF, multiple organ failure. And this is what leads to the initial morbidity and mortality of early acute pancreatitis, right? What the clinical presentation? Let's talk the clinical presentation. Now, having understood what really causes and how does it cause it, let's see what is the manifestation. The pain, as I said earlier, a typical pain. Now, apart from that typical pain, you can also have pain in the lower chest, in the back, in almost 50% of patients. The pain could be in left shoulder because of pleuritis. It could be generalized all over the abdomen once the pancreatic fluid leaks into the abdominal cavity. You can have a persistent pain for more than 48 hours in a dull fashion. You can have a partial postural relief. As we know, a typical pancreatic pain gets relieved when you bend for sit and bend forward. You get relief because the posterior part gets relief, right? Dry retching and nausea vomiting is very characteristic, almost found in 90% of patients. You can have hematemesis and melena in 5%. You can have hiccups, that is again because of the pancreatic fluid irritating your diaphragm. You can have a history of biliary colic if the patient has a biliary pancreatitis, or there could be a history of alcohol intake, either. And there could be mild icterus, and that icterus is basically because of pancreatic edema causing pressure over the terminal part of the CBD. The signs, you have fever in 76% of patients. Hypovolemia is a common finding, and this patient, when it comes to you with acute pancreatitis, let's say 24, 48 hours later, he has a dry mucosa, there is loss of skin turgor, there is tachycardia, 65% of patients, hypotension, cold and clammy skin. Mild icterus, I just saw 25% patients. Compression of the intrapancreatic CBD is the reason. Abdomen findings are non-specific in the sense you'll have a generalized tenderness. Muscular guarding could be there, 68% patients. Distension, almost 65% of patients. Bowel sounds may be poor over a period of time, and this patient over a period of time, that means post 48 hours, 72 hours, the patient can start presenting with subacute or intestinal obstruction or acute intestinal obstruction. That happens because of a jejunal adhesion to the transverse mesocolon, just underlying the inflamed pancreas, or later on end of the first week or later you could start getting a lump in the abdomen depending upon the amount of collection in peripancreatic region, right? Uncommon presentations could be retroperitoneal hemorrhage as gray Turner sign where you have a flank discoloration, or Cullen sign which is a periumbilical. And you can also have small tender fat necrosis nodules in the leg. Pulmonary signs are fairly common, and because there is a pushing up of the diaphragm on the left side and a reactionary pleural collection on the left side. So these patients are present with tachypnea, hypoxemia, lead pleural effusion, 10 to 20% of cases, and even ARDS. This is a typical, the Cullen and the greater in the flanks. This is a retroperitoneal hemorrhage which has crept into the flank, and this is a retroperitoneal hemorrhage in the periumbilical region. So Cullen and greater the sign are typical sign, but uncommonly found less than 10% of cases. So now I am suspecting acute pancreatitis. How do I diagnose it? That's the next question. So the diagnosis is both easy and difficult. In the initial stages, three times or more rise of serum amylase and serum lipase would be diagnostic. But there's a problem with serum amylase. We'll talk about that in the next slide. But what is important when we talk about these two enzymes is that they do not indicate the severity. So that basically means that suppose if you have 450 or 500 international in one patient and the other has shows 4,500, is it that the 4,500 is more severe? No. So the level of serum amylase or serum lipase does not is not indicative of the severity. Number one, and number two, they are never prognostic indicators. So don't say that I do a serum lipase today and 7 days later let me do again a serum lipase and see how the patient is behaving. That would be wrong. They are not prognostic indicators. What else would you find? Hyperglycemia. You would find a polymorphonuclear leukocytosis. You will find a raised aminotransferase level in the in acute pancreatitis. Almost 95% predictive value for diagnosis of acute biliary pancreatitis. And that brings us to an important point that biochemically, what suggests acute biliary pancreatitis with 97% sensitivity and 100% specificity. Number one, liver transaminase, that is ALT, gallstone disease demonstrated on ultrasound, and a raised pancreatic enzyme. All three together would suggest that 97% to 100% time this patient will be having an acute biliary pancreatitis, not peritonitis, acute pancreatitis, not peritonitis, right? Urine amylase, not a very good measure. I just noted it down because that was usually done initially. CRP is non-specific. Anything more than 10 milligram is abnormal. You will have levels of 150 milligram per L, but that just suggests an acute disease in the body. It doesn't tell you it's acute pancreatitis. And then comorbid condition, which is very important, is the BMI. And those patients who got a BMI of more than 30 are liable to get a much more severe form of acute pancreatitis, right? But just a few words about serum amylase and lipase. This is an appropriate time to speak about them. Amylase, remember the first line, not specific for pancreatitis. Remember when we talked about the first lecture, when we were talking about the pathology, the physiology of pancreas and the investigative capabilities. We had talked about amylase. So elevation can occur in other patients also who can have a small intestinal obstruction, mesenteric ischemia, females tuber ovarian disease, and so on and so forth. We already talked about that. Preferably, measure the amylase level. It is not very specific for pancreatic pathology. We just talked about that. But remember one thing: that the serum half-life of amylase is short, 10 hours, and elevations generally return to reference range within few days. And maximum level is seen at 48 hours and falls 96 hours. So what does this tell you? This basically tells you the patient comes to you for the first time in emergency. Immediately, if you take a serum amylase level, it is usually not fruitful. Why? Because it starts rising beyond 6 hours, right? So as soon as patient comes to you, a pain within 1 to 2 hours, then you do a serum amylase, and you say his amylase is normal, this patient cannot be having acute pancreatitis. That would be wrong. Or another patient, let's say, who had come to you 5 days down the line, and you do amylase, and you say this patient cannot be with a normal amylase, you say he cannot be having acute pancreatitis, even that be wrong. So what we talk about, a very narrow window, and that is starting about 6 to 10 hours, reaching a crescendo at 48 hours, and then falling 96 hours. So that means it's going to be positive only late first day, second, third, fourth day. Beyond that, serum amylase would not be indicative of anything. Lipase has slightly longer half-life, and that's why it is slightly more specific for pancreatic pathologies, and they remain high for almost 12 days. As opposed to serum amylase, which remains high for only 4 days, lipase remains high for almost 12 days. More with acute pancreatitis who are presenting 48 hours after the onset of attack. I just not told you. 48 hours it starts falling. After 48 hours starts falling, but this would remain high. And in patient chronic pancreatitis, because of alcohol abuse, lipase levels may be more elevated in the presence of normal serum amylase level. So, in a nutshell, what we are trying to put across is that lipase is a much better indicator, would be a much better indicator throughout the first week, and that is why this is to be preferred over serum amylase level. But coming to the more important diagnostic capabilities and investigations, and these are the imaging studies. Now, imaging studies are recommended for what? Number one, I want to confirm the clinical diagnosis. Number two, I want to confirm what is causing that. So investigating the etiology. And very important, what is the severity of this acute pancreatitis in this patient? Three very, very important questions. Does the patient have acute pancreatitis? Number one, question one. Number two, what is causing his acute pancreatitis? And number three, what is the severity of his acute pancreatitis? all these three questions have to be addressed, which are usually not addressed only on the biochemical parameters, and that's why imaging studies become more important. Now, coming to the imaging studies, a plain skygram of the abdomen can help you to rule out perforations. So it gives you rules out a number of other diseases. So there it is basically a diagnosis by exclusion. Number two, you can have a sentinel loop. You find an isolated gas loop, either the jejunal gas loop or a wide duodenal C, and that is because of a localized paralytic ileus. So sentinel loop is a localized paralytic ileus because of proximal constriction, distal constriction, in between air gets trapped. Or you can have a colon cut-off sign, a similar thing because of spasm at the splenic flexure. So the air gets entrapped in the transverse colon, giving you the colon cut-off sign. We'll show you the next picture. A chest diagram may help you by just showing you left pleural effusion or collapse of the left basal part of the lung. An ultrasound is always done, although it is not confirmative acute pancreatitis, but it does one very important thing, and that is it is going to rule out a gallstone disease, which indirectly may tell you that probably this patient may not be having acute biliary pancreatitis, right? So it is to help you to decide whether the patient has a CBD dilatation, where the patient has a gallbladder stone. But a endoscopic ultrasound, EUS, and a Doppler's ultrasound for CBD, pancreatic details regarding necrosis and tumors is a very important part of the investigation if available. CECT is the gold standard for morphological status of pancreas, and it starts showing changes 72 hours down the line. So remember one dictum, that if you want to get a morphological picture of the pancreatic damage, a CECT is helpful only 72 hours. First day, second day, the CECT is not going to show you anything except for edema. That edema can also be seen on a plain ultrasound. So a CECT really becomes informative 72 hours after the onset of the attack. MRI equally informative 72 hours down the line. ERCP not indicated during the acute phase, and endoscopic ultrasound and MRCP are better imaging study methods in a patient with acute pancreatitis. Now see, we're talking about sentinel loop. See the sentinel loop? You can see it out here, and there's a colon cut-off sign. So there's splenic flexure. This is the air trapped inside the transverse colon. So that's the transverse colon. So sentinel loop sign, and that's the colon cut-off sign. Now, coming to ultrasound, I just now told you always first imaging, early detection of gallstone, dilatation of bile ducts. Pancreas, does it tell you anything about the pancreas? It may. 30% of the patients may show a pancreatic enlargement, decreased parenchymal echogenicity due to interstitial edema. Ultrasound can show up focal ill-defined hyperechoic areas, which suggest edema or hemorrhage in the parenchyma. It can show you blurring of pancreatic contours, which basically means there is pancreatic edema and surrounding adipose tissue has been affected. The fluid collection peripancreatic region is can be very clearly shown on ultrasound. So an ultrasound, as far as the pancreas is concerned, will show you two very important things in all patients: almost pancreatic enlargement and fluid collection if present. The rest of the things are plus minus. A serial ultrasound study for follow-up on type of contents and amount of fluid collection and cirrhosis is a very important part of imaging for acute pancreatitis. So you see, basically an ultrasound is not only for ruling out a gallstone disease, it also tells you about the CVD dilatation. But the retropancreatic part of the CVD, we all know ultrasound is not a very good informative procedure. But the other thing that ultrasound can help you with an acute pancreatitis, a serial ultrasound tells you about the nature and the progress of fluid collection, and of course the edema of the pancreas. The limitation of ultrasounds are always there. Why? Because in all these paralytic ileus, there would be varying to the in all these patients with acute pancreatitis, there would be a relative paralytic ileus, varying degree. And the more the paralytic ileus, the more the air entrapped inside the intestine, less a visualization on ultrasound. So that is a limitation, especially in the first 48 hours. And differential diagnosis between interstitial and necrotizing pancreatitis is not possible with an ultrasound. And that brings us to the most important, and that is the multi-detector CT finding, multi-detector CT or the CECT, which is very informative, either done as a non-contrast or it can be done as a contrast. And a triple phase CT is very informative. And what are we looking for? The best vision or the best evidence for acute pancreatitis is available with a triple phase MDCT, and the best visualization is the portal venous phase, 65 to 70 seconds post contrast. What are you looking for? Viability of pancreatic tissue, necrosis, easily seen on CT, peripancreatic inflammation collection, easily seen on CT, free air, easily seen on CT, and a renal halo sign. There's a renal halo sign you can see out here. What is the renal halo sign? Basically, renal halo sign nothing but apparent enhancement of the perineal fat. So surrounding here is what? The perineal fat, and outside genotus fascia. So perineal fat by an adjacent retroperitoneal exudate in the left anterior parietal space. So that gets highlighted as the renal halo sign. This is the area of necrosis. You can see the area of necrosis out here. See these area of collection and necrosis. So this is basically what you are seeing on a CT examination. And remember, we said the third question is how severe is my disease? How severe do I have? So the revised Atlanta criteria clinically divided the pancreatitis into two simple types, mild and severe. That is the clinical classification of acute pancreatitis, mild and severe. Later on, a third was also added in the severe subgroup as moderately severe. So what is mild acute pancreatitis? By definition, mild AP is nothing but inflammation with an absence of local or systemic complications. Mortality rate, see, 1%. A very good disease to have. So if you have a choice between the types of acute pancreatitis, logically also, you would say I would like to have a mild acute pancreatitis rather than having a severe acute pancreatitis. Why? Because I would not be having any local complication, I would not be having any systemic complication, and the mortality rate is less than 1%, right? So absence of local or systemic. As opposed to severe AP, both of these things would be present. So presence of local complications in which form? Necrosis, abscess, cirrhosis, and or systemic inflammatory response syndrome, systemic complication leading to what? Leading to multiple organ dysfunction or multiple organ failure. And the mortality shoots up. See, 1% here, 20 to 50% here. That is how high the mortality is in a patient of severe acute pancreatitis. As I said earlier, the severe has now been divided into two, a subgroup, moderately severe and severe. Moderately severe, here you have a presence of local complication or systemic inflammatory response syndrome, but it is transient organ failure of less than 48 hours. So, by definition, if you're talking about a moderately severe, you're looking at the systemic manifestation having been there only transiently for less than 48 hours, or local systemic complications without organ failure. OF is organ failure. Here OF is not off, it is organ failure. So in two instances, we like to call it moderately severe. There is no evidence of organ failure. Which organ are we talking about? Notably the renal and the other organs, renal and the lung, two important organs. So we are looking at the transient organ failure less than 48 hours, or there is no organ failure but there are local and systemic complications. But a severe is the most dangerous, and here you will have a single or multiple organ failure. So organ failure single or multiple organ failure more than 48 hours. And this classification, what's the need for this classification? This classification is very, very informative in what? It tells you about the severity, so you can prognosticate this patient, and very important, you can try this patient. Which patient requires urgent treatment? So essential for the all important proper initial treatment of the disease. That's why you need to know whether this patient has got mild or severe. Apart from the fact that I can easily tell this patient, return the patient, look, your patient has got mild, he's not going to die, he'll be alright within 4 days, 5 days, 6 days. That's one part of the story. But the more important part of the story is I want to recognize that patient who's going to likely go into local complications, systemic complications. I want to identify that patient who's got severe acute pancreatitis. So that is the whole reason why this revised Atlanta criteria becomes more important, right? So that is one clinical type. The second clinical division or clinical classification of acute pancreatitis is a time-based classification. So that was basically the severity base. Now let's talk about the time base. And time base classifies acute pancreatitis into two groups: early and late. Early basically means within 1 to 2 weeks of onset. Later phase means after 1 to 2 weeks of onset, right? Now, within 1 to 2 weeks of onset. So why the need to do this? Because in both of them it could be severe, non-severe. That is one part of the story. But what is more important is that we have to recognize in early acute pancreatitis, the mortality and morbidity is most commonly because of multiple organ failure or multiple organ derangement, dysfunction. But post 1 week, usually it is a severe form, primarily dominated by local complications, and mortality is usually septic. So see the difference. In first week, I'm worried about the general circulation of the patient, the systemic inflammatory response. I'm not worried about the local complication right now because those local complications have not reached to a stage where they're going to cause mortality or morbidity to that extent. But post 1 week or post second week, now what is happening? I've taken care of the general patient, the general care of the patient, but now this patient has got a local problem, and that local problem relates to what? To the pancreas. And what is the local problem of the pancreas? That is morphologically classified according to Atlanta into just two groups: interstitial edema and necrotizing. There is no hemorrhagic, nothing else, right? So there is no term as acute hemorrhagic pancreatitis, which was initially a very commonly used term. So just two terms. More commonly, 70 to 80% of these patients of early, later, or patients who have got the mild or the clinical severity grade, the they would be having morphological only two types. One, interstitial edematous pancreatitis, which is usually the mild variety, and the necrotizing pancreatitis, 20 to 30% occasion, usually the severe or the later phase variety, right? So that's a morphological classification. So now you see, Atlanta has done three things. It has classified clinically as base severity, severity based, clinically time based, and morphological classification. Now, this is a very, very important figure, and you should see this overview. If you remember this overview, you will remember your acute pancreatitis. You need, at least you'll remember the important things of acute pancreatitis. You don't need to go into the details, right? Now, you see here the central point of the acute pancreatitis: early 1 to 2 weeks, late after 2 weeks. We just saw that in the last slide, right? Both can be severe and non-severe, severe and non-severe. Now, here early cases, they are, if they're severe, if non-severe, no problem. The patient is all right within 48 hours. Forget about that patient. So forget about this group. Nothing to worry about. What about the severe? A severe patient usually would be having SIRS. Because remember, I told you 1 to 2 weeks, the local complications do not matter. They are not severe enough within the 1 to 2 week to make a change or be cause for mortality. And remember, I just now told you what causes mortality in the first to 2 weeks, 1 to 2 weeks. It is basically the generalized symptomatology or the generalized abnormality, that is SIL. So if the patient has got severe type of acute pancreatitis in the first week, it is probably SIRS leading to organ failure of less than 48 hours, sorry, more than 48 hours, multiple organ failure more than 48 hours, and ultimately death. That is severe. If it is non-severe, it has to be less than 48 hours and the patient is all right. Coming to the second group, and that is late after second week, I have two types. One is the interstitial edematous type and the necrotizing type. So see, there is a clubbing of the morphological classification along with the severity and the time. See, everything, all the three that we just now talked about. We talked about what? We talked about severity, we talked about what? Time, and we talked about morphological. All three have been taken into account out here. See here, severity, time, 1 to 2, and then the interstitial necrotizing. So if you have interstitial edematous, it can be severe, non-severe, and you got organ failure, complications, so on and so forth. You can go ahead and look this up. This basically means pancreatic necrosis and this peripancreatic necrotic collection, right? But look at this central line, and that is fluid collection. So apart from the fact that necrosis is occurring or inflammation is occurring in the pancreas, there is also fluid collection, and that collection can be without necrosis or with necrosis. And based on without necrosis or with necrosis, you can have an acute pancreatic fluid collection, which after 4 weeks would be termed as PP cyst or pseudopancreatic cyst. You can have an early acute pancreatic necrosis before 4 weeks, and if it becomes walled off later on, it becomes walled off necrosis beyond 4 weeks. Just go back and look at this slide again after the completion of the lecture. Now, coming grading of severity. Now, assessment of patient for grading of severity We just now said mild, severe, and that. So, but how do we say it is mild, or we just now said there has to be organ failure? But is there some objectivity to it? When do we say the organ dysfunction, organ failure? Now, for that, the number of parameters will helps you to decide whether the patient really is suffering from severity or not. Because in the first slide that we talked about, see the severity, we said mild, we said severe. So far, so good. But we are given wide generalization. Absence of local or systemic complication. How do we say there's absent? Or transient organ failure. How do we say it's organ failure? For that, you have to have some kind of objective parameter. So, what are these objective parameters? So, when should you assess this patient first of all? It should be assessed at the time of admission, and in the first week, 24 hours, 48 hours, and on the seventh day. Right? That is standard protocol. The patient comes to you at the time of admission, and then subsequently, 24 hours down the line, 48 hours down the line, and 7 days down the line, you have to reassess this patient and to judge whether this patient is really in which severe group, mild or severe, and among the severe, mild severe, or major severe. How do I say that? What can help me? Number one is CRP, more than 150 milligram. I told you it is non-specific, but a peak at 48 to 72 hours is what is seen in CRP. So before 48 hours becomes useless. So I have an attack today and you get my CRP done today within 12 hours, my CRP would be normal or just within normal range. Useless. So it becomes useful only 48 hours after the onset of the disease. A Ranson grading, which includes 11 parameter, is one of the standard grading methods for defining acute pancreatitis. Initially, it was only for alcoholic, but now Ranson's is both for alcoholic and biliary pancreatitis. Remember that. So it is but the problem with this is a positive predictive value of 50%, negative predictive value of 90%, right? Primarily used in inpatient setting. That means it cannot be used for an outpatient. The patient has to be admitted. Basically, it is used helpful in defining the operative treatment what the patients require, defining multiple organ failure, defining SIRS, and vascular leak if it is occurring in a particular patient. And if you have a Ranson score of 0 or 1, it predicts that complication will not develop. I have mild disease and I'll be absolutely all right. But if it is 3 or more, then I have had it. I have to be treated differently. And that is where Ranson is important. The third is Apache 2, which the figure of the grading of more than or equal 8 tells you that it is severe disease. But the disadvantage of Apache 2 is a very, very complex method of defining the severity, not specific for acute pancreatitis. It is for any kind of severe disease and based on age, which easily erroneously upgrades the score. So, say if you've got 30 years and the other patient is 75 years, both have got equal diseases, a patient 75, the score will shoot up. So, that basically tells you that the positive predictive value is very, very low, of only in the region of 43%, and negative predictive value of 89%. Other grading of severity by Glasgow, more than 3. CT severity index, that is the CT scan severity index, Balthazar's. You can have modified Marshall system for organ failure, the SIRS scoring system, the BISAP, which is bedside index severity in acute pancreatitis, and number of other markers are still investigational. You can remember them, but none of them have got a specific role to play. Serum lipase and amylase, just to repeat, they are not prognostic parameters. They are not related to severity, so they do not form a marker for grading of severity. Glasgow criteria, apart from Ranson, this is valid for both gallstone and alcohol-induced pancreatitis. And I said earlier, score of 3 or more that indicates severe pancreatitis, and the patient should be transferred to ICU. So, what does the Ranson or Glasgow tell you? Anything if it is 3 or more, I have had it. I'm going to have a severe disease. So immediately this patient is going to be treated in an ICU, not in a routine inpatient facility. So that is where Ranson and Glasgow helps you. Grading less than 3, treat this patient routine inpatient. More than 3, treat the patient ICU. Right? And what are the Glasgow criteria? To remember it, you have a mnemonic known as Pancreas, and every word of Pancreas stands for the parameter. You can look this up. I'm not going to repeat this here. So starting from Pancreas, and in front of it you have the parameter that is going to be looked up for the scoring system. Right? Now the Glasgow criteria. If the patient score ultimately, once you add it up, it's 0 to 2. The mortality is 2%. So I'm in the safe zone. But if I have severe disease, right from score 3 to score 8, my mortality creeps up to see 100%. So, Glasgow and Ransom criteria is a very, very important criteria for prognosticating also. Here, this shows you the 11 parameters in Ransom, and here you got a Glasgow, and see what is there. On admission and within 48 hours. That's why I told you it has to be a serial estimation. Admission 24 hours, 48 hours, 7 days. Right? 48 hours most important. That ultimately gives you the final Ransom score or a final Glasgow score, which is going to help you. Now, Ranson's criteria, we talk about Ranson's criteria, can easily be remembered. I told you the Glasgow criteria, the mnemonic is pancreas. The mnemonic for Ranson's criteria is GA law and chops. That is a firm of lawyers. So GA law and chops, and each word stands for one parameter. I'm not going to go into that. You can just look this up. So the concerns are there in this slide. I've labeled everything. The concerns with Ranson's criteria there, the Ranson score greater than 2 has a sensitivity of only 84 and specificity 89.8%. So it's not 100%. Score and severity of acute pancreatitis cannot be determined until 48 hours have passed since admission. See, I told you the final score is available only 48 hours down the line. 11 parameters make it difficult to use conveniently. And original Ranson, when the Ranson criteria was made, it was for patients lying between 30 to 75. So what happens below 30 and beyond 75? So this group of patient, pediatric or beyond 75, are not very well diagnosed on the basis of Ranson's criteria, or I would say not triaged based on Ranson's criteria. So use of the current Ranson criteria also cannot be a very good prediction for patients living in high altitude. So these are the concerns with Ranson criteria. So coming to the differential diagnosis of acute pancreatitis, you have upper abdominal pathology, any acute pathology, like example, acute cholestasis, you can have acute cholangitis, a bowel infarction, like example, mesenteric vein thrombosis, you can have acute intestinal obstruction, perforation, so on and so forth. So the raised amylase and lipase level of less than 3 times Celsius probably not acute pancreatitis, but I told you it is not confirmatory. So you have a raised level of amylase and lipase more than 3 times. Amylase, remember the number of diseases, all these diseases we just not labeled. All of them will have a raised amylase, can have a raised amylase, but lipase is more specific acute pancreatitis, right? Coming to the treatment of acute pancreatitis, if it is an early disease, what is the early disease? Basically mild disease, first week. So what are you looking at? Aggressive fluid management is the primary treatment of all acute pancreatitis, whether it is severe, non-severe, whatever. Primary fluid management with what? Isotonic crystalloids and preference to ringer lactate, right? It has to be guided by what? Monitoring with parameters like urine output, the central venous pressure monitor, or even invasive, and that is the mean arterial pressure. Or you can also have cardiovascular parameters in the routine, that is the heart rate and the blood pressure. But here you can have a CVP. So either invasive or non-invasive monitoring of fluid therapy. A constant pulse oximetry is very, very important because most of these patients would have a very early alteration in their pulmonary capacity. So keep the oxygen at 95 millimeters of mercury. Above that, if not, then give this patient oxygen, supplemental oxygen. Early enteral therapy is again a mainstay of treatment of all kinds of acute pancreatitis, very easily possible in the mild, but in severe where there is a lot of paralytic areas, early enteral therapy may not be possible. But then try to bring this patient to early enteral therapy. And in what form? Either give this patient enteral therapy through the mouth, but if can't be given a mouth, put in an ice tube. So nasogastric tube therapy is again enteral therapy. Or you can even do a jejunostomy field. That is also enteral therapy. Basically means what? The food is being, or food digested or partially digested, is being pushed inside your intestinal lumen. So that is basically enteral feed, and should always be preferred over a total parenteral nutrition. Remember, there was a time when everything was, the nutrition was totally dependent on TPN. This was, I think, about 30 years back. But as they understood the complications of TPN, they said TPN is not a good form. You should prefer enteral feed, right? Analgesics has to be very, very important. Why? Because this would help you in relieving the pain, which is a very, very important part of acute pancreatitis. Very, very painful. And in patients with acute biliary pancreatitis, a same admission laparoscopic cholecystectomy is an important part of the treatment. What about severe acute pancreatitis? Apart what we have already talked about, apart from that, this patient may require nasogastric drainage. So it was nasogastric feeding in the last one. Here he may require nasogastric drainage. Antibiotic prophylaxis can be considered. CT scan is essential, especially if you're suspecting organ failure. And I told you 72 hours down the line. ERCP may be indicated 72 hours, supportive therapy for organ failure, and if nutritional support is required, consider nasogastric feeding. Right? Now, the severe disease additional supportive would be organ supports. Like for example, for kidney, you may require hemofiltration. You can require peritoneal dialysis. Peritoneal dialysis per se was also advised as a formal treatment of acute pancreatitis. They said if you push in fluid inside the peritoneal cavity and wash out all the pancreatic juice, that would lead to less chemical peritonitis inside the peritoneal cavity, not proven to date. So peritoneal dialysis as a formal treatment, not indicated, but peritoneal dialysis as a treatment for renal support, yes, indicated. For lungs, supportive therapy, for cardiovascular supportive therapy may be required. Antibiotics, a very, very big question mark for prophylactic. There's no consensus. But those who want to give it, why there is no consensus? Because the frequency of surgical intervention does not decrease with antibiotics, or infected necrosis does not decrease with antibiotics, or mortality in severe AP does not decrease. So if you're using antibiotics, say that probably I'm helping the patient. Helping with what? Are you actually decreasing the rate of infected necrosis? No, you're not doing that. Are you decreasing the mortality? No, you're not doing that. Are you decreasing the frequency of surgical intervention? Not doing that. That is one part of the story. The other side of the story, and another thing, another disadvantage is that you are probably causing a super infection with in 5 to 10% patients with a gram-positive staph and candidiasis. Right? The other part of the story is says that no, I am preventing it. So if you want to give prophylactic antibiotic, there are people who give it. That's why the first line is no concessions. It doesn't say you cannot. It says no concessions. If you want to give it, prophylactic metronidazole, Cipro, imipenem, cefuroxime for a maximum period of 14 days. But if you have proven infection, then cultures and sensitivity-based antibiotics should be done. When we were studying, there were a lot of drugs which were advised, even I think 15, 20 years down the line, up to 2000, 2005, a lot of drugs, like for example, atropine, somatostatin, and you had aprotinine, gabaxate, mesylate, which are basically inhibitors of activated protein enzyme. They said it's going to deactivate trypsin. They are all no longer used. Say they have no role. I just included these names out here to tell you. PF is platelet activating factor. So none of these drugs have any role, and they have no role to play in present day management of acute pancreatitis. Right? Now, coming to interventional treatment in the first week. So we are talking about the first week. Remember the first early phase. So does ERCP help? Now, again, two views to it. Your Love and Bailey says it is indicated. The other standard textbooks say ERCP is not indicated as a routine in acute biliary pancreatitis unless and until, and this stands to reason. You should not do ERCP in every patient under the belief that this patient got gallbladder stone, so I should do an ERCP. So every acute biliary pancreatitis does not require an ERCP. It's only indicated, number one, if they are associated cholangitis, persistent CVD obstruction as seen on other imaging studies, and older patients with comorbidities which precludes a definitive surgery at a point in time. So this patient has got gallstone pancreatitis, and you know he has got gallstone pancreatitis, and you know later on he may develop recurrent pancreatitis, and I have to do what we call a secondary. But suppose the patient is so old, he's got comorbidity, he's got a very weak heart or lung, and I can't do a lap chole. In that patient, a ERCP may be indicated. And that brings us to the most important thing, and that is lap cholecystectomy at the same sitting. The basis is 30% of patients with acute biliary pancreatitis, would have a recurrent disease. See, one third, a very high figure. That means if 100 patients of acute biliary pancreatitis are there, and you let them follow a natural course, 30%, and one third of them are going to come back to you with recurrent pancreatitis, acute pancreatitis. So it is indicated in all mild AP, acute pancreatitis, during the initial admission, and that is defined as early lap chole. So early lap chole in acute biliary pancreatitis is defined as the same admission lap chole, and that is usually within the first 7 days. If your patient has got severe acute pancreatitis, do not do a laparoscopic cholecystectomy 6 weeks later, and that is an interval laparoscopic cholecystectomy. Treatment post first week, the complications and their management. I think we'll talk about this next time because that is a separate chapter in itself. There are a lot of complications we'll talk about that takes a lot of time. So I think we'll finish this off today at this point. That is the early management of acute pancreatitis, and the late management in the post first week we'll talk about later. Thank you for your time, and this lecture will be uploaded tonight or tomorrow onto the YouTube, and you can go ahead and look at it. You know my address on the YouTube, that is Rajiv Sinha JHS. You just put in on the YouTube Prime and look at the lecture. Thank you for your time.